something sitting in millions of medicine cabinets right now that most people don't fully understand. And I'm not talking about something obscure or exotic. I'm talking about one of the most commonly prescribed classes of drugs in the entire world: blood pressure medication. Specifically, amlodipine, losartan, lisinopril. If you take any one of these, or if someone you love does, I need you to stay with me for the next several minutes, because what you're about to learn isn't meant to frighten you. It isn't meant to make you distrust your doctor. It's meant to do something far more valuable than that. It's meant to make you the kind of patient who notices things early, who understands what their body is telling them, who doesn't end up in an emergency room because nobody connected the dots in time. Here's what most people don't realize. The danger with these medications isn't usually that the wrong drug was prescribed. The real danger, the kind that quietly builds, happens when people don't understand what the drug is actually doing inside them. And so they miss the warning signs. They explain away the symptoms. They assume it's age, or stress, or just a rough few days, and then something serious happens. That's the conversation we're going to have today. 11 things you genuinely need to know about these 3 blood pressure medications, starting right now. Welcome. I'm Dr. David Aid, and if you're new here, this channel is dedicated to giving you clear, practical, trustworthy health education, the kind that helps you make better decisions before a crisis forces one on you. Now, blood pressure medications are extraordinarily effective tools. When they're used correctly, with proper understanding and proper monitoring, they genuinely save lives. They reduce stroke risk. They protect the heart and kidneys. They extend quality years. But here's the reality of modern healthcare. A typical doctor's appointment doesn't give either side enough time. There's barely enough time to review the prescription, confirm the dose, and check the blood pressure reading. There isn't always time to sit down and walk a patient through everything that could happen once they start taking that medication. So people leave the appointment with good intentions, a bottle of pills, and only about half the information they actually need. That gap between what was prescribed and what was truly explained is where patients get hurt. Today, we're going to close that gap. We're going to talk about which side effects are normal and expected, which ones demand attention, and which ones are genuine emergencies. We're going to talk about food interactions, kidney changes, lab results, and the everyday habits that can turn a safe, appropriate medication into something dangerous. By the end, you'll have a practical, honest framework for understanding what's happening inside your body when you take amlodipine, losartan, or lisinopril. And that understanding is one of the most powerful health tools you can have. Let's begin with what I think is the single most misunderstood concept in blood pressure medicine. People tend to think of blood pressure medications as interchangeable. They think they all do the same thing: they lower my pressure. And in terms of the final result, yes. But the way they get there is completely different. And that difference matters enormously for understanding what your body might experience. Amlodipine is a calcium channel blocker. What it does is relax the walls of your blood vessels by blocking the movement of calcium into the muscle cells that line those vessels. When those muscle cells can't contract as tightly, the vessels open up, resistance drops, and blood pressure falls. Lisinopril belongs to a class called ACE inhibitors. It blocks an enzyme in the body, angiotensin-converting enzyme, that would otherwise signal blood vessels to tighten. Block the enzyme, reduce the signal, the vessels relax. Pressure drops. Losartan is an ARB, an angiotensin receptor blocker. Instead of blocking the enzyme like lisinopril does, losartan blocks the receptor that receives the signal. Think of it like this. Lisinopril stops the message from being sent. Losartan stops the message from being received. Different step in the same chain, but that difference produces meaningfully different patterns of side effects. Why does that matter practically? Because if you start coughing after beginning lisinopril, and you assume all blood pressure medications will make you cough, you might stop treatment entirely. That's a dangerous assumption. If you develop swelling in your lower legs on amlodipine and you assume your heart is failing, you may panic unnecessarily and make poor decisions under stress. If you feel fine on losartan and assume there's nothing to monitor because you feel fine, you may miss a potassium problem building silently in the background. Once you know the class, You understand the pattern. And once you understand the pattern, you stop being blindsided by what your body is telling you. Let me say that again, because it's worth sitting with. Understanding the class of drug you're taking means you can interpret your symptoms more clearly, you can ask better questions, you can recognize warning signs earlier. That knowledge alone can be the difference between a manageable side effect and a medical emergency. Let me tell you about a woman I'll call Gloria. Gloria was 72. She was disciplined, organized, exactly the kind of patient most physicians hope for. She took her amlodipine every morning without fail. She came to every follow-up. Her blood pressure numbers improved beautifully. On paper, everything was perfect. But then one afternoon, she looked down at her feet and realized her shoes weren't fitting right. By evening, her ankles looked puffy. Her legs felt heavy and uncomfortable. She thought she was gaining weight. Her daughter worried it might be her heart. Gloria, in her own words, was quietly terrified. What nobody had taken time to explain to her was this: amlodipine can cause a very specific, well-understood type of swelling in the lower legs, and it has to do with the way the drug works. When amlodipine relaxes blood vessels, it tends to relax the small arteries more efficiently than it relaxes the veins. Blood flows into the legs quite easily, but the return flow back toward the heart is a little slower. Pressure builds up in those tiny capillary vessels near the ankles, and fluid begins seeping out into the surrounding tissue. That's why people often say they feel fine in the morning, but by evening their socks are leaving marks on their skin. Now, this swelling is not a heart failure. It's not kidney failure. It's not dangerous in and of itself, most of the time. But the problem isn't the swelling alone. The problem is what happens when nobody explains it. People get scared. They avoid social outings because of how their legs look. They start quietly skipping doses of their medication on days they want to go out. And that is how a manageable, medication-related side effect becomes uncontrolled blood pressure. If your ankles are swelling and you're taking amlodipine, please don't self-diagnose. And please don't quietly abandon your medication. Bring it up. The conversation is straightforward, the options exist, and you deserve to have them explained clearly. Elevating the legs in the evening can help reduce the discomfort. In some cases, the dose may be adjusted. In others, a different medication class may be more appropriate. But guessing is never the right answer. If there is one side effect that comes up more reliably in conversation about ACE inhibitors, it is this one: a dry, persistent, nagging, scratchy cough that simply will not go away. And what makes it so frequently missed is the timing. This cough doesn't always begin within the first few days of starting Lisinopril. Sometimes it appears after a couple of weeks. Sometimes it takes months to fully develop, which means people blame the wrong thing entirely. Allergy season, dust in the bedroom, acid reflux coming back, a lingering cold from 3 months ago, dry winter air. They try every remedy, replace every filter, take every lozenge, and the cough keeps coming back because the actual cause is sitting in their pill organizer every morning. The cough is usually dry and unproductive, not dramatic, not wet, just relentless, often worse at night, often worse when lying down. People lose sleep, their energy drops. They feel worn out without fully understanding why. The cough happens because ACE inhibitors cause a buildup of a substance called bradykinin in the lungs and airways. Bradykinin is an irritant to the respiratory tract, and for a significant portion of people, some estimates suggest up to 30%, that irritation produces a cough. Here's what I need to make very clear. This cough, as annoying and disruptive as it is generally not dangerous. But there is something else associated with ACE inhibitors that absolutely is dangerous, and I need you to understand the difference. If you develop swelling of the lips, the tongue, the face, or the throat, particularly if swallowing becomes difficult, or if breathing feels even slightly compromised, that is not a wait-and-see situation. That is not something to monitor over the weekend. That is emergency care, immediately. This reaction is called angioedema. It is rare, but it can develop rapidly, and it can become life-threatening within a short time. ACE inhibitors like Lisinopril carry a recognized risk of this reaction. ARBs like Losartan carry a much smaller but not zero risk as well. So hear this clearly. A dry cough is a nuisance that deserves a conversation. A swollen tongue or throat is an emergency. Those are two entirely different situations, And knowing the difference may matter enormously in a moment when calm, fast thinking is essential. If you have the cough and it's affecting your quality of life, speak with your doctor. Losartan was in many ways developed specifically as an alternative for people who couldn't tolerate the lisinopril cough. Switching classes is a valid, well-established option, but only after a real conversation, not a quiet self-decision. Here is a risk that hides in the most ordinary, responsible-seeming places. And I want to tell you about a gentleman I'll call Robert because his story captures exactly how this happens. Robert was 74. After his blood pressure diagnosis, he became serious about his health. He cut back on sodium. He started reading food labels. And proud of his new habits, he switched from regular table salt to a salt substitute because he'd read it was better for his heart. What Robert didn't know was that most salt substitutes replace sodium with potassium chloride, which means every meal Robert was seasoning was adding extra potassium to a body that was already on Losartan, a medication that can raise potassium levels on its own. The combination quietly pushed his potassium higher than it should have been, and he started feeling off, a little weak, some strange sensations in his muscles, occasional fluttery beats in his chest. His labs eventually revealed elevated potassium, high enough to require immediate attention. Robert wasn't careless. He was trying to be a model patient, and that is exactly why this conversation matters. Both Losartan and Lisinopril can cause potassium to accumulate in the blood, a condition called hyperkalemia. And elevated potassium is dangerous because of what it does to the heart's electrical system. It can alter the rhythm. It can cause arrhythmias. In severe cases, it can be life-threatening. The challenge is that high potassium often doesn't announce itself loudly. Some people feel muscle weakness, cramping, a tingling or pins and needles sensation, unusual fatigue, or heart palpitations. But others have almost no symptoms at all, which makes the lab result genuinely important, not just routine paperwork. So what should you watch for in daily life? Potassium doesn't only come in supplement bottles. It shows up in salt substitutes, often in large amounts. It's in many electrolyte powders and sports drinks. It's in certain seasoning blends marketed as heart healthy. It's in some meal replacement drinks. These aren't medications, which is exactly why people don't mention them to their doctor. If you take Losartan or Lisinopril, make it a habit to read the labels of every seasoning, electrolyte product, or supplement you use, and bring them up at your next appointment. It is not a trivial question. It is a real safety conversation. This is one of the most emotionally charged misunderstandings in blood pressure medicine, and it causes patients to make dangerous decisions with genuinely good intentions. When someone starts Losartan or Lisinopril, their doctor will often order blood tests a few weeks later to check kidney function. The tests look at things like creatinine and eGFR, numbers that reflect how efficiently the kidneys are filtering waste from the blood. In some patients, those numbers shift slightly after starting the medication. Maybe creatinine goes up a small amount, maybe eGFR dips a little. And the patient, often reading results through a patient portal before anyone has called them, concludes, understandably, that the medication is damaging their kidneys. That conclusion, while completely natural, is sometimes wrong, and acting on it can cause real harm. Here's the reality. Losartan and Lisinopril don't just lower blood pressure. In many people, particularly those with early kidney disease or diabetes, they provide a protective effect on the kidneys over time. They do this by changing the pressure dynamics inside the tiny filtering units of the kidney. But when you first start the medication, or when the dose increases, that same change in internal pressure can show up as a small, transient shift in lab values. The kidney isn't being damaged. The environment it's filtering in is changing. And for a mild, expected shift, one that remains stable and doesn't keep climbing, that may actually be a sign the drug is working exactly as intended. The critical question isn't simply, did the number move? It's how much did it move? Is it continuing to rise, or has it stabilized? What else is going on in the body? These are questions that require context, clinical judgment, and follow-up, not a midnight decision to stop the medication based on a portal notification. A woman I'll call Sharon came close to that mistake. She was 71, had both high blood pressure and early kidney disease, and her doctor had specifically chosen Lisinopril because of its protective kidney benefits. When her first follow-up labs showed a slight shift, she saw the numbers before anyone called, panicked, and nearly stopped the medication that night without speaking to anyone. That conversation, the one where her doctor explained the difference between expected change and dangerous decline, changed her entire understanding, and it kept her on a medication that was actually protecting her. Lab follow-up isn't just routine box checking. It's part of the treatment. It's the mechanism that allows the monitoring of a drug, powerful enough to save lives, but nuanced enough to require attention. Most people think of blood pressure medication as fixed. You take the same pill, you get the same effect day after day. But the body is not fixed. It changes with temperature, activity, hydration, and illness. And some of the most dangerous medication-related emergencies happen not because the drug changed, but because the body changed around it. Here is the scenario that comes up far more than people realize. You're taking Losartan or Lisinopril. You catch a stomach bug, nausea, vomiting, maybe some diarrhea. You're not eating much. You're not drinking enough. You're sweating from a mild fever. Your fluid balance drops significantly. And then you take your usual morning dose. Because that's what you always do. Because you're proud of never missing a dose. But now your blood pressure medication is acting inside a body that is significantly depleted. Your blood pressure, already lowered by the medication, drops further because there's less fluid in the vessels to maintain it. When you stand up, the blood doesn't return to your head quickly enough. The room tilts. You grab the wall. Or you don't grab anything in time. A man I'll call Frank was 78 when this happened to him. He had a bad stomach virus for 2 days, couldn't keep much food or water down, but still took his Losartan faithfully every morning. That evening, when he stood up from the couch, he nearly collapsed. He didn't. He caught himself. But he ended up in the emergency department. His blood pressure had bottomed out. His kidneys were showing stress from the combined impact of dehydration and medication. Frank didn't fail. He was actually trying to be disciplined. But he'd never been told that illness changes the rules, that there are days when skipping a dose, after calling for guidance, is the safer choice. That hydration and medication dosing are not separate topics. If you use Losartan or Lisinopril, talk to your prescribing doctor now, before you get sick, and ask what you should do during an illness that involves vomiting, diarrhea, poor fluid intake, or heavy sweating. Get a plan in advance, because in the middle of a stomach bug is not the moment to figure this out from scratch. This is one of those interactions that shocks people precisely because every individual piece sounds so ordinary. Blood pressure medication, perfectly common. A pain reliever from the drugstore shelf. What could be more routine? Maybe a water pill on top of it. Also a standard prescription. Put them together in certain circumstances, particularly when the body is even slightly dehydrated and you have the conditions for genuine kidney strain. Anti-inflammatory pain medications like ibuprofen and naproxen, the drugs people reach for reflexively after knee pain, back soreness, or weekend gardening, can constrict the blood vessels that supply the kidneys. The kidneys are remarkably sensitive to blood flow, and when flow is reduced, they respond. At the same time, ACE inhibitors and ARBs are also affecting kidney blood flow dynamics. And if a diuretic is in the picture too, reducing fluid volume further, the kidneys can find themselves in a genuinely stressed state. People almost never mention over-the-counter pain medicines when listing their medications, because they don't think of them as medications in the meaningful sense. They're just something from the store, just something for the weekend pain, just something that doesn't count. They count. A woman I'll call Carol was 73 and managing her health reasonably well, or so she thought. Lisinopril for blood pressure, a water pill for leg swelling, ibuprofen several times a week for arthritis in her hands. She didn't connect them. Nobody had connected them for her. When her labs started showing signs of worsening kidney function, when her blood pressure became more erratic, it took careful review of everything she was taking, prescription and non-prescription, before the picture became clear. Removing the regular anti-inflammatory, finding safer pain management alternatives, and tightening up her monitoring allowed things to stabilize. The lesson here is not to be afraid of pain management. The lesson is to be transparent about everything you take. Every supplement, every over-the-counter medication, every herbal product. Because drug interactions don't only happen between prescriptions. This is the side effect people most often laugh off. I just got up too fast. I'm fine. It only lasted a second. Everybody gets a little dizzy sometimes. And in a 30-year-old, a brief moment of dizziness when standing up is probably inconsequential. But in a 75-year-old living alone, that same moment of dizziness, that same brief window where the blood pressure hasn't caught up to a rapidly upright body, can produce a fractured wrist, a head injury, or a broken hip that changes the entire trajectory of a person's life. All three of these medications, amlodipine, losartan, and lisinopril, can cause dizziness, particularly when starting them, when increasing the dose, or when something else in the body has changed. The medical term for this kind of dizziness is orthostatic hypotension, a sudden drop in blood pressure when moving from lying down or sitting to standing. What makes this particularly important is context. Nighttime bathroom trips, moving quickly from the bed to the light switch, standing up from a recliner after a long evening. These are exactly the moments when dizziness strikes and the environment offers the fewest things to grab. A man I'll call Joseph was 80 years old, lived independently, took great pride in that independence. 2 days after his dose of amlodipine was increased, he woke up in the middle of the night, stood up in the bathroom, and felt the room tilt sharply. He caught the sink just in time. He didn't fall, but he was shaken, badly. When I asked whether anyone had told him to rise slowly, to sit at the edge of the bed for a moment before standing, to be especially careful in the first days after a dose change, he said no. He'd been told the medication would lower his pressure. He'd never been told what that would actually feel like in his body, in his house, in the dark. That is the difference between prescribing and preparing. Mild dizziness may settle as the body adjusts, but fainting is not a side effect to dismiss, and repeated dizziness is not something to quietly endure. Tell your doctor. There may be adjustments to be made or precautions to put in place that make this medication safe for your life as it's actually lived. Blood pressure fluctuates. That is not a flaw. It's how the body works. Your blood pressure changes when you move, when you sleep, when you're anxious, when you've had caffeine, when you've just rushed across the house to find the monitor, when you're emotionally activated by whatever you read in the news this morning, when you're having this conversation with yourself in your head about whether the number is good or bad. And yet so many people, intelligent, caring, well-intentioned people, are making major decisions about their medication based on a single reading taken at the wrong moment. A woman I'll call Diane was 67 and had developed the habit of checking her blood pressure whenever she felt worried about anything. She'd get a high reading, then check again immediately. And again. And again. She'd fill pages of a notebook with numbers, all of them slightly different, and become convinced that her lisinopril wasn't working. She was anxious. She was exhausted from the anxiety. The anxiety itself was pushing her readings up. When the approach was slowed down, same time each day, a few minutes of rest beforehand, a consistent measurement method, a much calmer picture emerged. Her medication was working. The problem wasn't the drug, it was the interpretation. This matters because when people believe their medication is failing, they start making impulsive, emotional decisions. They take an extra dose trying to force the pressure down. They skip doses because they think it's pointless. They demand changes based on noise rather than signal. Blood pressure medications like amlodipine, losartan, and lisinopril are long-game tools. They work through steady, consistent use over time. Their effectiveness should be judged by trends measured correctly over weeks, not by startled glances at the monitor after a stressful phone call. If you're monitoring your blood pressure at home, which is genuinely valuable, build a simple routine. Rest for 5 minutes first. Use the same arm. Sit properly. Measure at the same time of day, typically morning before medication, and possibly again in the evening. Track the trend over days and weeks. Bring the record to your appointment. That is useful data. A panic reading on a bad afternoon is not. Medications like these work through consistency. They are not rescue tools. They are not for acute episodes. They are designed to maintain a steady level of effect in the body, day after day, over the long term. And that means missing doses, doubling up doses, or experimenting with timing creates instability. Sometimes in the readings, sometimes in the body. The most common dangerous mistake people make when they miss a dose is taking 2 at once later in the day, thinking they're protecting themselves from a pressure spike. In reality, doubling up can produce a rapid, steep drop in blood pressure, causing the dizziness, weakness, and near fainting that then scares them into another poor decision. A man I'll call Martin was 75 and took his lisinopril faithfully, except when he didn't. If he forgot the morning dose, he'd take it at lunch. If he felt his pressure was high in the evening, he'd convince himself to take another, just to be safe. One night, after a worrying home reading, he took an extra tablet because he was afraid of having a stroke overnight. The following day, he felt washed out, weak, and unsteady. He was frightened by his own protective instinct. The general guidance for most of these medications, though you should always confirm with your own prescriber, is to take the missed dose when you remember, unless the next scheduled dose is coming up soon. If it is, skip the missed dose and resume normal. Never double up to compensate. If you're genuinely unsure what to do after a missed dose, call the prescriber's office. Most have nurse lines or messaging systems for exactly this kind of question. It takes 3 minutes and eliminates the guesswork entirely. Consistency is not a minor detail. It is the entire mechanism by which these medications work effectively. A stable daily habit is worth more than any emergency catch-up dose. We've talked about 10 important things today, but this last one, number 1, is the one I most want to stay with you. The best blood pressure medication is not the one that produces the prettiest number on paper. It is the one you can take safely, consistently, and sustainably because it fits your body, your life, your other health conditions, and your reality. A medication can look like a complete success in the chart and be a quiet failure in the real world because the person taking it is suffering with side effects no one asked about, missing sleep from a chronic cough, quietly embarrassed by their swollen ankles, or slowly drifting away from taking it at all because nobody made them feel like the discomfort was worth addressing. I want to tell you about a woman I'll call Teresa because her story brings everything we've discussed into focus. Teresa was 70 years old. Her blood pressure numbers on Lisinopril were excellent. Any doctor reviewing her chart would have been satisfied, but Teresa was coughing every night, sleeping terribly, waking up exhausted, and beginning to dread the pill she was supposed to take every morning. She didn't tell anyone. She assumed the answer would be, well, you need the medication, so just live with it. She didn't want to be difficult. She didn't want to be the patient who complained. So she started forgetting the pill. Not every day, just sometimes. Then more often. Then her blood pressure crept back up. Then everyone seemed surprised by the change in her readings without understanding the reason for it. Teresa didn't need a lecture about compliance. She needed a doctor who asked the right questions and gave her options. When the connection between her cough and the medication was finally made explicit, and the possibility of switching to a different class was discussed, everything changed. Not because the new medication was better in an abstract sense, but because it was better for Teresa, for her body, her sleep, her willingness to actually keep taking it. That is what real effective blood pressure care looks like. Not just the number, the person. And this is the practical truth I want you to carry with you. Side effects are not personal weakness. They are data. A swollen ankle is data. A dry cough is data. Dizziness when standing is data. Muscle cramps are data. Weakness after a stomach bug is data. These are your body's signals, and they deserve to be heard and evaluated, not ignored and not catastrophized, but interpreted intelligently. Your role is not to diagnose yourself. Your role is to notice, to track, and to report. Too many people believe that being a good patient means never complaining, never burdening the doctor, never making a fuss. But silence is not strength when it comes to medication safety. Silence allows problems to grow unaddressed until they become crises. Speak up early. That is what good patients do. Let me give you a simple, clear framework to take away from today. If you take Amlodipine, watch for ankle and lower leg swelling, especially by the end of the day, flushing or warmth in the face, headaches, particularly in the first days after starting, dizziness when standing, especially at night, a heavy or uncomfortable feeling in the legs by evening. If you take Lisinopril, watch for a dry, persistent cough, scratchy, tickling, worse at night, dizziness, especially with position changes, and most importantly, any swelling of the lips, tongue, face, or throat, which is an emergency and needs immediate care. If you take Losartan, watch for dizziness or lightheadedness, muscle weakness, cramping, tingling, or an irregular heartbeat, all of which may indicate potassium is running too high. Changes in how you feel during or after illness involving dehydration. With Losartan and Lisinopril especially, regular blood tests matter. They are not optional. They are part of how the medication is used safely. With all three, be aware of what you're taking alongside them. Salt substitutes, pain relievers, supplements, these are not trivial. They are part of your medication environment. And with all three, consistency matters more than perfection. Miss a dose occasionally? That happens. But know what to do and never try to compensate with an extra one. Here is the thing about blood pressure medication that rarely gets said directly. Millions of people take these medications every day in a kind of fog. They know the name, they know the dose, they know they're supposed to take it. But they don't know why the ankle swelled. They don't know why the cough started months after beginning the medication. They don't know why their kidney numbers shifted, or why their doctor suddenly asked about ibuprofen, or why getting sick with a stomach virus might require a phone call about the pill they've been taking for 2 years. That fog creates fear, and fear creates poor decisions. But the moment you understand the mechanism, the moment you understand what the drug is doing, how it works, what it affects, and what it's communicating when things change, the fear shrinks. You stop imagining that every symptom is the beginning of something terrible. You stop dismissing things that genuinely deserve attention. That balance between unnecessary panic and dangerous denial is exactly where safety lives. And understanding gets you there. If someone you know is taking Amlodipine, Losartan, or Lisinopril, please share this video with them. There is a very real chance they are managing their medication with less information than they deserve. You may be doing them an enormous favor by passing this along. And if you have questions about your own situation, about side effects you've experienced, about something in today's video you'd like me to expand on, leave them in the comments. I read them. They often become the foundation for future videos. If this kind of honest, practical, trustworthy health education is what you've been looking for, please subscribe and hit that notification bell so you don't miss what's coming next. Because there are more conversations like this one ahead. Conversations designed to give you the information that protects you before you need it desperately. Take care of yourself. I'll see you in the next one.